Key movements to build back strength after ACL surgery.
Okay. Yeah. I I would look at this like as starting as soon as possible. I think is the best thing because ACL surgery is a fucking bitch. There's like you have a lack of function until you get the surgery. You're immobile. You're non-weight bearing for a while after. So it's going to very much start in the sense of PT. A lot of that more passive stuff. Like we actually recorded, I think, a whole podcast on this not too long ago. We were talking about like getting into knee flexion, rolling your knee in and out on the chair. So like very passively getting into knee flexion because that's going to be the thing, right? Is when someone has an ACL repair, typically what's going to happen is they're going to lose knee flexion. So that's going to be the range of motion that is kind of on the time clock to come back. Is that if we don't address this as soon as possible and get as much progress as quickly as we can, then it might be something that goes unresolved. We may never get access to end range knee flexion if we don't intervene sooner rather than later. But there's a fine line that you have to play with that, because if you take it too far too soon, then guess what? Your new ACL is fucked. And that's worst case scenario here. So that's where this starts with me, is starting passive, starting with going down that kind of rehab progression of moving from passive, active, active assisted or passive assisted. Sorry, you say this better than me. I just think of it as passive and active, and then active is a scaling resistance as we go through. So the idea is that probably starting with less dynamic movements. So after I get a passive range of motion, I want to do something to start to activate the muscles and stabilize that joint. And it's probably going to start with isometrics or very small range of motion contractions, and then working to slowly start to build back the musculature that is going to support that knee through that range of motion. So knees are pretty easy. We have quads, we have hamstrings, we have calves. So working through knee flexion, knee extension, that's essentially what we have to do. That is going to be very limited by your ability to bear weight and stabilize the knee at first. So adding into that lateral stability and control through rotation at the hip is going to be the thing that allows you to not overstress the knee in any of those positions, and then just going down that rehab route in a reasonable way, but also understanding that as you go through this, it's probably going to start, especially for athletes, it's going to start in a stimulus that's below what they can handle. So being careful to ride that line in the short term, like 3 months or so, that's going to be that time where like you just very literally have to let the tissue heal, right? Like they're drilling through bone, they're either using cadavers, they're using hamstring, hopefully not, but you need to let that surgery take before you can really start to stress it in any sort of meaningful way. And then once it does, then you need to start to graduate the stimulus to what you're capable of.
Yeah, I think just to maybe layer on top of that a little bit more and kind of like an outside in view, it's, there's always, you can always do something. Like I think of this every time I wake up in the morning and I'm like, oh, we're doing this again? Like, fuck's sakes. One of the first things I do on my really bad days is unsubscribe from emails. It is the lowest lift that I can possibly do while I still, I don't even have my feet on the floor yet. I'm contemplating just jumping at this point. I'm like, like on days where I just don't feel like doing dick, I can unsubscribe from an email. I can roll over, grab my phone. It's 3:47 and I go, oh, fuck. I don't want to do anything. It's like, this is proof that I can do something. And it's something that, invests my time into the future, because I don't get fucking Allegiant Airlines emails anymore. Allegiant was the one I unsubscribed from this morning. And it's like, okay, you can do something. Great. I think in the interest of an ACL injury, rehabilitation, surgery, it's okay. One, you might ask yourself, and it's not necessarily a useful enterprise for a lot of people, but you may ask yourself, where were there up and downstream inadequacies in movement that led to this, right? So I think about, the tibial rotation and the femur rotation as those kind of make the knee. And when we see that, that very localized pathology, when we see a tibia move away from a femur in a particular plane, more commonly like, a valgus medial to lateral blow. It's like, could that have been avoided? Could we have adopted a better position? Now, you don't want to play the magic 8 ball of injuries that, only if we could do this exercise, we wouldn't probably not smart or judicious or even useful at the end of the day to play that type of mental math in your head. So it's, there are things though that are going to be a little bit more peripheral as you mentioned, in that early stage that the tissue is actually healing post-op, where the tissue at the ankle or the tissue at the hip is still ready to go, right? You didn't get hip, knee, and ankle surgery in some cases, I hope, and I know a few where that's been the case, and it's fucking catastrophic and an absolute dumpster fire to recover someone from that. But if you just had ACL surgery, it's like, okay, we have this 3-month window now where we can really focus, up that progression of, we're talking about active, passive assisted, passive, active, or sorry, fuck, they got me fucked. Passive, active, active assisted, active, no, fuck. Passive, active assisted, active resisted. Got it.
Nailed it.
But you can move, you can start moving, you can start doing things localized, maybe active assisted at the ankle while you're strictly passive at the knee, and while maybe you're active assisted at the hip. Right? You got the Dawn Joy brace on, you're locked in at 170 degrees, 180 degrees, like your knee is fully extended. And, you can still move your hip and keep your knee very safe. So maybe we're doing something like non-weight bearing, passive active assisted hip internal rotation or pelvic mobility drills. Like there's a lot we can do up and down the chain, because when we start looking at getting back, everyone can get to like 70% or 75%. That last 25%, I think a lot of therapists, a lot of people, they know like, all right, the knee bends, and it's like, yeah, but maybe they don't really understand the relationship of how does the position of the ankle affect the position of the tibia distally, which will then affect how it responds proximally. So we start to do all these tests with our feet on the ground, and it's like we don't have access to the range of motion, and we see it at the knee, but the problem could be, and could have maybe always been, a limitation at the foot and ankle. So, when I think the question was directly around exercises, obviously it's going to depend on what phase of rehab you're in. Is this acute, subacute, or chronic? And I think one thing when you're going through ACL and a rehab of any kind, there are return to play protocols, and people usually name them after themselves. And one of the things that I see most often that's a little bit detrimental to progress in the long term, like you said, it's like get to it early. I think too often we set too stringent a time constraint on progress. Like I am an advocate of like very much performance-based return to play protocols, which means if you can do this, and now mind you, the things that you're asking them to do need to be self-limited and constrained to a tissue that's able to do it, right? You don't want to outkick your coverage, so to speak, with exercises and load progressions. So you have to be very careful of what your progressions look like. But I think a lot of times the arbitrary passing of time in a rehab progression can be deleterious to the long-term goal. As you mentioned, expediency is really going to be what rules the roost when it comes to getting someone back. And a lot of that's to do with the neurological changes that happen as the brain sort of goes plastic around that area. So one thing that I'm a huge advocate for in rehabilitation is when you come up with the landmarks, make sure that they are at least punctuated with performance markers, not just punctuated with time. We are at the 2-week mark. We are now going to progress to isometric. We are now at the 4-week mark. That means we can now graduate to the eccentric. It's like, what your week post-op, what if you're already at the performance mile marker? Do you just stop? Do you just keep doing it? Do you just wait until the clock strikes midnight and your knee turns into a pumpkin or whatever Cinderella bullshit you think time has anything to do with? It's like, no, I think using obviously subjective overlay of pain with the objective overlay of performance, I think that's how you really pull yourself out of it. Now, I don't think we gave a single exercise in that entire diatribe, but I think from a principles base, that's something that we can look at. So with key movements, build back to surgery, key movements is move correctly. And I mean that in like a more literal or more metaphorical sense of like, use principles to dictate your rehab, use performance to dictate your rehab, and maybe don't fall victim to sort of the normal paradigm, because there is going to be a reversion to the mean principle, right? We are taking the averages in these studies, in these protocols. And, there are arguments to be made. ACL is a tougher one to make the argument for, but long-term outcomes of some of these surgeries, not maybe particularly ACL, but some similar to long-term, 6-month, 12-month, 18-month, a lot of the results of surgery, musculoskeletal surgery, begin to normalize over time. And so if you don't want to normalize over time, you might want to take a different approach out of the gate. The reason these things are normalizing is they are taking normalized approaches. It is very much a living example of the reversion to the mean principle. So ACLs are tough. Good luck. But you use your head. I think a lot of people get scared.
Yeah.
I think, we lose that thought of, human resiliency, which humans are crazy, crazy resilient. But the second we get hurt really bad and we need a knife to get us better, it's like, there's a fragility that sets in. That's dangerous. Because if you think you're fragile, you're fragile.
Yeah. Yeah, a lot of ACLs are also an acute injury. I think that's something to keep in mind. But at the same time, it's an acute injury, especially if we're talking athletics, because of a chronic stressor. So understanding what that chronic stressor is that puts you in positions where you might be at risk for re-injury, and being able to account for that in the training and in the rehab process. So, if it's a lot of lateral cutting, if it's like a non-contact injury, like how did it happen? What led to this injury happen? Which is different than a valgus blow, but understanding that there are going to be specific positions that this person, depending on the level of function that they would like to regain, that they will be exposed to, where they will be at risk for re-injury. And thinking about that in the rehab, what can we do to make sure that this isn't something that is as exposed in those positions?
Yeah, I agree. I'm laughing because I'm thinking about one particular ACL case, and I'm thinking about one ACL case specifically that you and I both witnessed a potential rehab combine. Yeah,
Yeah,
don't do that. Okay,
yeah, don't do that.
All right,
We're gonna train valgus blows to the knee.
Oh, Jesus Christ! All right, let's do one. We're gonna do one more. Okay, what does a typical leg day look like? Warm up, main work, etc. Now, this is gonna have two very different answers.
I've been training a lot of hypertrophy lately, so I'll answer this because I'm assuming that's where this question is coming from, based off of the phrasing. But I'll give it my answer, and then you can give it yours. So, the main progression that I go after on my leg day is barbell back squat, and that's pure preference. That's not because I'm chasing hypertrophy. It's because I fucking love doing it, and I want to squat a ton of weight. So that's my number one priority. That's my first order exercise. And I will typically, if I'm in like a commercial gym, what I will do to get ready for that, I'll start on a 45-degree hip extension. So I'll do that to get the glutes to, my line of thinking is kind of normalized pelvic rotation. So I'll usually have a bit of an isometric at the top, like full contraction, probably like 2 sets of 15. And then I will do the adductor machine because my hips are fucked. I don't know if it's herniated discs. I don't know if it's sprained ankles. I'm fucked. Like I have a lot of shit where lateral stability at the hips is just not what it needs to be to train like I train. So I need to do things to make sure that I can stabilize the best that I can to my ability if I'm going to try and squat as much weight as I can, which I do every single time I put a bar on my back. So it'll be like 2 sets of 15 on the adductor machine. Then I'll go walking lunges, probably 2 sets, like body weight, walking lunge with sprinter pose, about 20 steps. And then I'll get on the barbell. I'll do whatever my barbell work is for the day. Lately, I've been on 5, so I'll try and work up to a top set of 5, probably do a back off set for quality and speed. And then I will move to something that is more externally stabilized. So lately, I've been pairing back squat with a hack squat, and then I'll go quad extension, hamstring curl, seated calf raise. That's my leg day.
Easy. Yeah, I'm doing a heavy bar on my back. It's been a minute. Especially if it's been heavy. What am I doing? I've been taking to in warm-ups now using medicine balls, but like not like for soft tissue work and position stuff. So I'll basically lay sideways on a medicine ball.
Mm.
Where before I would use like a foam roller, go through the IT. Now I just stick like I don't know, a 40-pound medicine ball, something with a decent diameter, like right in sort of the cavity of my innominate bone. And I just like get some frontal plane movement that way passively, try and get some big breaths in, maybe move it up to the rib cage, do that. And then I think what's been really helpful is I used to go kettlebell, just jam it into the ab. And like,
Oh yeah.
the idea of maybe you're getting into the psoas, probably not, but there's oblique there for sure, maybe some fascia. I've been like sticking with this ball. So my warm up really consists around this like 40-pound medicine ball that I just like put in different places and try and just breathe a bunch. So I'll go like innominate, just kind of like getting some passive frontal plane movement, rib cage, maybe a bit of extension, maybe a bit of flexion. And I just finish with like, just like putting it right on my belly button and laying face down and just taking a deep breath in through my nose. I find that a little bit more responsive to loosening up and the hip flexors, whatever. Just because it's not so much surface area, or so it's more surface area, therefore it's not so much pressure. Where like a kettlebell handle can just be like gnarly, like you're just like not even relaxed. There's no point. You're just more sympathetic. You're just on higher tone. So I've been doing that, and then have had 2 leg days of late. First is going to be walking lunges, dumbbell. So just do a couple sets of body weight. 25-pound dumbbell, 50-pound, 60-pound dumbbells for as many as I can for 2 top sets. And then it's a pendulum leg press, a quad extension, and a Bulgarian. And then the second leg day is calf raises, standing calf raises, deadlifts, pendulum leg press, hamstring curl, seated. Or no, line. That one gets a little, but yeah, it's fairly straightforward, and it's funny because off the jump, someone asked us, and the question was like 3 exercises you would do forever. The majority of my training sessions are that now. Are like
Yeah.
the manifestation of distilling down. Obviously we were talking about across the board exercise we would do forever, and like 2 that I listed without even remembering it were in there. Lunges and deadlifts. Those are in my leg days and will always be in my leg days. If that you were to ask me top 20 exercises you could do forever, you're pretty much going to list every exercise in my program currently and probably into the future.
Yeah, I don't do very many exercises. One thing I do want to note on leg day, though, because you know this, and I've been dealing with this for about a year now, is I get some fucking gnarly knee pain. And a lot of it is because of asymmetries that stem from prior injuries. Like my right ankle, it's I don't know what the fuck's holding it together at this point. Um, just pain. It's just pain that holds my right ankle together at this point. I've herniated discs. Like I just some fucked up weight distribution patterns when I do bilateral movements. So that kind of results in me lacking internal rotation on my right leg. And something I found with that pattern is like a lot of tightness in the lateral hip, a lot of tightness in the lateral hamstring. So I have a lack of tibial rotation on that right side. It's kind of cranked into external rotation. And I train Olympic weightlifting, which requires a ton of internal rotation, both at the hip and the tibia. So a large reason of why I was getting knee pain is because I just didn't have access to that range of motion. So something that I found to be 2 things I found, that the seated hamstring curl and actually the standing hamstring curl, like the kneeling one, are very helpful for me in gauging where I'm at in terms of like that lateral tibial rotation via lateral hamstrings. So that's one thing that I keep in there indefinitely. But also the seated calf raise is probably the best movement I've seen to isolate tibial rotation. Right, as you go into that dorsiflexion, I think about keeping pressure right at the base of that first metatarsal and really internally rotating the tibia as I go down. And as I come up into plantar flexion, I think about letting that weight roll across the ball of the foot towards that 5th metatarsal as I get into tibial external rotation. So that's something I'll just sit on there. I'll do single leg, like sets of 15 or 20 with no weight, literally just to get my tibia to rotate through full range. And I'll do that twice a week, and it's been the best progress I've had with my knee pain, is just doing that on a consistent basis. So that's an honorable
Wow.
mention there.